Welcome, everyone, to the Medipreneurs Interprofessional Conversation of June of 2024. We've had some of these before, but this is the first one this calendar year, I believe. And I'm thrilled that you all are here. So to get us started, we're going to go around and do introductions with name, location, and profession. And then I'll give us more information as to why we're here and sort of what our hour is going to entail. So if I call your name, I'm just going to go around the circle the way you all are on my screen. So I'll start. I'm Michelle Fritsch. I am a pharmacist and I'm in Charlotte, North Carolina. Marty.
Hi, Marty Ng from Dayton, Ohio, and I am also a pharmacist.
Denise.
Denise Wiseman in Seaview, Washington, and I'm a ruckus maker.
And it cut out. Say it again. You're a what maker?
A ruckus maker.
Love it. Carol.
I'm Carol Van Horn, a pharmacist in Portland, Oregon.
Andrea.
Andrea Laschak, Cary, North Carolina, pharmacist.
Chanel.
Hey, good evening. I'm Chanel Carter, and I'm a pharmacist here in Barbados.
That's exciting.
It is.
Love it. Sam.
Hello, my name is Sam Bisking. I am a fourth-year pharmacy student, and I've got 2 more days left on my first APPE rotation for that. And by trade, I am a T53 turbine engine performance analyst, and I just started a pre-doc research fellowship at UMKC, my pharmacy school, and that has yet to pan out as far as what that will look like, but that's the stage I'm in.
Lots of celebration, Sam. Fantastic.
Renarda.
Renarda Jones, Columbia, South Carolina, pharmacist.
Igor.
Hi, Igor Gorlatov. By profession, right now, I'm a leadership development and executive coach, and I also run a private mentorship program, Advisory 5.
And you're in Charlotte.
And I'm in Charlotte, North Carolina, correct.
Irene, will you please introduce yourself to us by your name, your location, and your profession?
Irene Croswell, pharmacist in Tualatin, Oregon.
Fantastic. We just had 2 more people join us, so I'm going to give them a chance to get fully linked up. Welcome,
Michelle.
Tina. Welcome, Lila.
Hi, I'm
Hello.
Michelle.
We've just done introductions. So can I ask each of you to tell us your name, your location, and your profession? Gina, I'll have you go first.
Yeah, hi, my name is Gina Tran. I also go by Twee, like Tweety Bird, but don't call me Tweety Bird. My profession, I am a pharmacist, oncology pharmacist, and I am from Atlanta, Georgia.
And Lila.
Yeah, I'm Lila Gabbard, and I'm a social worker in St. Charles, Missouri, just outside St. Louis.
Beautiful. Oh, I'm so thrilled that you all are here. So tonight is about getting to know each other and brainstorming the value of getting to know each other. If you know me at all, you know I've been on this kick for a while, but I think we've got a long ways to go. So I want to tell you my beliefs as to why I think this is important. And then I'm going to challenge you with a couple of questions. and we're going to go into breakout rooms to discuss those. So does that sound like a worthwhile use of your next 54 minutes?
Yep.
Awesome.
Yes.
I believe there's tremendous power in us busting through all of the silos that separate us and in getting to know each other. I have to cheat and look at my notes. I think, and specifically with health professionals, we're a unique group in that we're incredibly highly trained, just not in business development. And I believe there are 3 key reasons that some people who are health professionals who start their own business are not successful. And I firmly believe us coming together reduces the risk of our businesses not succeeding. So one of those is loneliness. Has anyone ever experienced the loneliness that once you start out with your own business, without the connections that you're used to having, boy, it can just feel insurmountable. Another one is y'all have been wasting a lot of time, me included, in that we each went out and tried to figure this out on our own. Who's guilty? And imagine if we came together and supported each other through the process and we weren't constantly inventing the same wheel over and over again. And I believe that there's power in our businesses growing as we get to know each other to the point that it could include referrals, especially within a community. So I'm going to try something I've not used before. And we're going to hope that it works well, which is the polling. So do you know the other health entrepreneurs in your own geographic community? And then I see some are going in and answering the second one, which knowing local innovators like me could help me do what? Which of the options do you think would be the most beneficial to you? To brainstorm, share resources, be referral sources,
We
or
need
to
an all
collaborate
of the
to actually
above.
improve outcomes?
Absolutely, we need that one.
Mhm.
So it sounds like most of you have started getting to know your community. And I hope that that will be an ongoing effort. And there's interest in all of these. But right now, the one with the most votes is to collaborate to improve client outcomes. Denise, you said all of the above. I'm gonna move this so I can see you all. Does anyone else agree that you see benefit in all of them?
Yes.
Love it. That is fantastic news. So what I want us to do, I have heard while being on this quest, I've heard a number of people make statements like, they're my patients or my clients. Why would I share them with someone else? And I've heard statements like, it's my liability. You know, if I refer to you and you don't do a good job, that reflects poorly on me. I could potentially lose my client because they no longer trust me, or I could, you know, my client's outcomes could go down, which could reflect negatively on me. So all this fear and distrust. So I'm feeling like trust is one of the key elements of figuring out how do we come together as a community. So I'd like for us to go into our breakout rooms and just talk about that concept. What do you believe are the barriers to trust? And what are 3 tangible things? Decide as a group, what are 3 tangible things that could be done to help health entrepreneurs across the world, because we got Barbados here, across the world, enhance that trust factor? So I'm going to put you in groups of 3 to 4. Any questions before we go? I would love to hear what you just what you felt were maybe 3 key things. So let's start with room 1, Andrea, Igor, and Irene.
Well, I
Or
can,
do you want to, you summarize, okay?
yeah, I'm happy to summarize. I think we had three things that we touched base on, and Irene and Andrea, please fill in the gaps. So one was actually understanding the gaps that might happen because of planning and figuring out when things don't go according to plan, what do you do? The second thing was around just having focus of being not only in the business, but also working on the business and being open to kind of connections, finding the time and mental bandwidth to unlock those connections. And the third, space, and Irene, please correct me if I misrepresent what you shared, but it's like on the one hand, vulnerability, and on the other, openness from like providers and physicians to the value that can be provided by some of those services of entrepreneurs, and creating those like human to human, not B2B, B2C, but human to human connections. So I'll stop there. Irene, Andrea, could you please fill in?
That's very true. And I'm very excited to see that Gwen Sampson has joined us on the call. She is one of the with a group that we're working here with in Oregon to make a difference for their patients and assisted living and SNF, et cetera, as they do transitions of care. And you know, we're going to fill in the gap. So welcome, Gwen.
Thank you. Happy to be here.
So glad you're here. So let's go to room 2. We got Twee, Gwen, and Renata. What did you come up with?
Gina, did you want to summarize?
You can summarize, Renee.
Oh. We
No.
talked about what you said, Michelle. You know, one of the barriers of referring is just trusting that the person's actually going to do what they said they're going to do. And if they don't, then it comes back on you. And then another comment was made that people may say they offer a service, but that's actually not the service they actually provide once the person gets there. And then conversation was had about pharmacists, folks not knowing on an interdisciplinary team what pharmacists do. They think that we're, again, just behind the pharmacy counter and not knowing some of the clinical aspects that we can bring to the team. So those were the 3 things that we came up as barriers in our group.
Those are big. The second one, the service actually provided is not the service that you were told they'd provide. Was that kind of what that one was?
Yes.
Remind me to come back to that one in a second. Love it. All right, room 3, Denise, Lila, and Marty.
I think one of the things we talked about was just proximity, kind of making the connections, making it easy for them to find other professionals. Sometimes they don't even know where to look. And once you start talking and getting in proximity, developing those relationships, then you can build that trust.
Good point. So room 2, you guys talked about the service actually provided doesn't match the service you were told would provide. Part of the trust and getting to know each other, then that's a good point, is going to be how do you get that assurance that you understand what that person is going to do, how they're going to do, what your referral client could expect. Can that be done with a conversation? Does that require a visit or a personal experience with their service?
I don't know. That was Sam's point, and he had to leave.
I mean, I think like anything, I think it's achievable. It just needs, the expectations need to be clearly laid out, and goals, you know, achievable goals and measures, you know, in order to, you know, build that trust. But if you set the unrealistic expectations, like, and there's nothing measurable, then how are you going to attain it?
That's a good point. Andrea, you had your hand up.
Yeah, that one actually kind of piggybacks in with what I used, and I kind of used my most extreme, hopefully nobody ever goes through it example. But I had just made a referral for a clinical consult to someone that I know, trust, and knew the business. And even then, I had asked permission of the client if I could send a summary to the other person that I knew and said, does this fall into your wheelhouse with the services you provide? I mean, I know, well, it's for, it was Asha, right? So I know what Asha does, but I still wanted her to have eyes on a summary and said, even though I know what you do, this is what she's asking, does this fit? And, you know, and will you be able to deliver the outcomes that she's asking for? And then the first meeting we had, we attended together so that I could hear it. And then that way the person in the referral, because she came to me first, asking for me to do the service. And then when I heard what it was, I was like, well, this is not my specialty. I know someone, I know 2 or 3. I'll go to the first one, which was Asha, but we actually attended that first consult together with her permission.
So very much that pass the baton method, right?
Exactly, literally in the same room. And then she communicated with both of us and said, I'm good. Asha sounds like my person. And then I did get like a follow-up note. We are having our first meeting on this date. So I had a general idea. It wasn't like I was deep in the management of it. But then when, catastrophe struck, the person, I knew to reach out to that person. So I was also, because the client still has needs, right? And in this case, she would have never known. And so I know sometimes I've been accused of being a little too deep in with my folks, but I feel that in terms of trust, that was a good way to do it, because one, I made sure that the service met her needs, because the clinician had looked at the summary. I was in the call. And then I had just the most basic of, this is what I'm going to do. Thanks for the referral. And knew that when something went sideways, that I could step back in and then find another person if needed. So I think that kind of piggybacks into what
does.
group 2.
Great communication. Chanel, let's try again.
Yes. So what I basically was trying to say before is that my major barrier here in Barbados is communication. It's not just interdisciplinary, but also between the pharmacists themselves. The actual sector, you find there is no communication, there is miscommunication, and then sometimes the patients are left to basically send or advocate for themselves.
That is not just in Barbados, let me tell you. But did I hear you correctly that you were talking about that there's miscommunication or no communication at all, and the patient is left in the middle trying to communicate between the players involved in their healthcare? Is that right?
And sometimes it's between pharmacies, not just doctor and pharmacist or nurse and pharmacist. Sometimes it's between actual pharmacies.
Within the profession, there's just as much miscommunication. I was just at a pharmacy conference today, and I've been at a couple of conferences recently that are interdisciplinary, like you said, Chanel. And now that I'm thinking about this, it's like I'm watching it happen. I think there are way too few true innovators like you all within the overall healthcare space. So many of the sessions I attended were very much within silos and within sort of traditional parameters. And that has gotten us to a certain point. But I feel like healthcare is in need of some innovation, of some new and bright ideas. But I personally feel like we've got to break down the silos before we'll be in an opportunity to really work together to come up with those bright new solutions. Is that making sense? So if you were at Medipreneurs, you heard me talk about this. I think of, oh, yes, someone said something. I think of innovation from within the health system as being in the box and you're trying to raise the roof a little bit or maybe build out an extended window, but you're not able to create really big change. You all have been very brave. Many of you left salaries and benefits and things that supported you to go out and try to figure out how to do things different and better that better uses your skills. So I think you have the kind of innovative, creative thinking that's going to ultimately come back into the health system, feed back into the health system, more innovative ideas. So this is very much in line. Say it again.
Sorry, Michelle. Yeah, how do we do this with entrepreneurs? You know, I see this interrelation, team collaboration in the hospital setting. You know, everybody work together as a team to support one person. It takes a whole village to care for one person. But when I decided to step away from the hospital setting because I just see so many drugs keep on giving to the patient. What are we doing out there in the primary care in the world that cannot prevent all of this, you know, easy preventable disease state and patient keep coming to the ER, keep coming to the hospital? What are we doing out there? So now I come outside, become an entrepreneur, and on of this silo again. How are we going to bring all the profession together? How can we utilize each person's strong point in order to support one person? That is the question we have to answer, and I haven't still figured it out. And on the stress and networking and all that, it's just too much for one person to handle, to run the business and to make connection and to care for the patient all at once. Is just overwhelming. Yeah, overwhelming to the point that I just want to go back to my silo, really.
So that really is the next question of what is that one really tangible next step that could be taken to keep moving this initiative forward, that we get to know each other across silos, especially out here in the innovative entrepreneur world, so that we over time can support each other and be a more unified voice toward new solutions. Is that too broad of a question? I want to see what you do with it. So I'm going to put you back in breakout rooms for 6 minutes and then welcome back.
Hi, Renata.
Hey, Lala. You know, you got lights on now. Love it. So what you're about to tell me is going to partly be my marching orders for the next little bit. So I'm anxious to hear. Room 1, Denise, Gwen, Igor, and Renata. What's tangible thing or two that we could really do to keep this movement going forward?
I would build relationships. One, Igor was identifying the network and the collaboration he's creating through what he's purposely working on. And Renata, what I heard was we need to support each other. And we're going to have those days of not so good and better. And how do we be there for each other so that we can lift some of this, we can feel that just that joy in the awareness that we're not alone and others care about what we're doing, and what we're doing is so important. I kind of ad-libbed a little bit there, guys.
Something is going on weird with your sound, Denise, but I think I got it. That
I'm
we
sorry.
just, all right, we need to pull together and make sure that we never have those moments of feeling alone, because what we're each doing is so important. So we want to find those ways to support each other. Did I summarize that? Okay, group one. Super. Anything else? Not that there had to be. I asked you for one thing, but I don't want to move on if you have more to say. Okay, how about room two? Lila and Chanel.
Right. So I was with Lila, and there was another lady. I did not catch them. Right.
Gina.
Right. So we were actually in the process of discussing. She was mentioning that she was in the hospital setting where they had groups, teams. You had doctors, you had nurses, pharmacists, dietitians, the whole list. But once you came out of the hospital setting, you don't seem to have that team for the patient. And I think she was going towards, I guess, suggesting that we form these type of teams on the outside for those patients who are private patients. I guess if you want to call them cell groups, networking groups, what have you. If there's a way that we can probably set those up in our communities and then share it with other communities, and then we can go from there. And we can start with this forum, I guess.
Yeah.
That is what I guess that's where she was headed, but we got cut off.
But that makes sense, that if we can do it inpatient, why can't we do it in the community? And kind of to your point earlier, you've got the players, but they don't have a good way to communicate with each other. So it becomes very, very fragmented.
Michelle, I got why can't we take transitions of care outside of the hospital or living facility boundaries and create a team and a connection between hospital pharmacy and the practitioners that are in that setting or in a living facility setting, and the community pharmacists or independent pharmacists that are out there with the patients in the community, because things change in that gap. So I mean that kind of goes along what you were talking about, Chanel. I think, about having the team, but not just have it siloed in a hospital setting. Like we have those handoffs where there's communication between the hospital pharmacists and the community pharmacists. So
Handoffs, that's a key word. I like that. And then room three, Andrea, Irene, and Marty.
you want me to go? I was talking about the importance of communication and just speaking out. I was sharing the reason or how we met Gwen and the team at Ascent Healthcare was because I put something in the chat at a online seminar. The real estate specialist who helps seniors find a place was mentioning that patients were falling through the cracks when they transitioned from the hospital to home or home to a living facility. as far as they're managing their medication and health conditions. And I spoke up in the chat. That person connected us with the group at Ascent Healthcare. And, you know, we have an ongoing dialogue, but it's just a matter of looking for opportunities to interact with people who aren't necessarily the type of healthcare practitioner or entrepreneur that you are. And then we all know each other's, you know, or get to know each other's resources and strengths, etc., and be able to share that. You know, it's like, for instance, like Igor, you know, you know now what we kind of do. And it's like, oh, I've heard about, you know, pharmacists doing this. So, or a physical therapist or somebody like that, and, you know, like we can support each other. So, I mean, it's all about support and communication and handoffs, I guess.
Yes, please. It was going through my mind just now. In the hospital settings, you have rules and regulations to follow. So I'm thinking you have to work as a team because you have to follow those rules and regulations. Therefore, is it because on the outside, everybody has their own rules and regulations? Is that why it is so difficult for us to come together? Is there a way we can have, like I said, the cell groups formed, but under one set of rules and regulations where everybody understands, okay, this is where my boundaries are. It's time for me to collaborate with this person, and the patient then is in a smooth and efficient manner handed over to the next healthcare professional on the specific rules and regulations. That's my question.
I think that's a good point because, you know, I made that statement at a conference for PQA, and it was all around, you know, what the government now having to step in to do drug price negotiations. And my statement to the team was, if people would just do the right thing, we wouldn't have to worry about the government coming in to set up rules to tell us to do the right thing. And I think that's where we're at right now. And Chanel, you're absolutely right. In the hospital, you got these rules and regulations that you got to follow by. So everybody's working together. You know, even in the world of Medicare, there's certain things that you have to do in order to meet quality metrics. But when you go over to commercial, they could care less. They make decisions based on cost all day when it should just be on clinical first and then cost. But they don't have the same rules and regulations that we do in the Medicare space. So it again bogs back down to people. If people would just do the right thing and lead with the right intentions and do the work, I think we'd be better off as not just a healthcare community, but as a world in general.
And if I can add one more thing, working directly one-on-one with the patients, by the time they're in crisis and they're trying to deal with it, they almost don't care about the rules anymore, which is really sad. Because as much as I'm trying to, because I recently talked to an attorney questioning HIPAA for my practice, and he said, in truth, you should have confidentiality agreements, but not HIPAA agreements. He said, because you're technically HIPAA adjacent. You're not bound by HIPAA per se, but you do have confidentiality. But to take that piece the next step over, by the time the clients are trying to deal with all these different providers and all the different systems and documents that aren't or are on my chart or whatever, they're just like, send it through Drive. I don't care, and so, it which I don't necessarily agree with, but that's just the exasperation by the time, the end user is just so frustrated. They just want somebody to help them get through it. And so then you're trying to explain to people why you have information, and they're like, well, you shouldn't have that. And I'm like, well, you got me. And I've got this piece of paper from them, and they want me to talk to you, I mean, it's like, so.
I would love to continue this conversation. What if we did it in September? Because I know that we're hitting that busy summer time. And I thank each of you for coming and spending time here.
Thank you.
Thanks,
Thank you,
y'all.
Abby.
Have a good night.
Thank you for having me. Have a good night.
Night.